Next chapter is rhabdomyolysis. What is rhabdomyolysis? It is lysis of skeletal muscle caused by any mechanism that results in injury to myocytes and their membranes. Acute necrosis of skeletal muscle fibers and leakage of cellular content into the circulation causing myoglobinuria. So what are the causes of rhabdomyolysis? It is drug of abuse and alcohol, medications, muscle diseases, trauma, neuroleptic malignant syndrome, seizures, immobilization, infection and strenuous physical activity plus heat related illness. Statins can cause myalgia and myopathies. Increase CK level. What is the significant increase in CK level? More than 5 times of normal. So an elevated CK is what is more than 5 times of upper normal limit. So common conditions associated with rhabdomyolysis in adults are trauma, drug of abuse like your MDMA, ecstasy or caffeine. If you drink excessive caffeine, it's going to result in rhabdomyolysis, so don't do it. Cocaine, ethanol, heroin, LSD, methadone, methamphetamine, opiates, phencyclidine, ketamine, everything that you like cause rhabdomyolysis. Then there is environment, heat, excessive muscular activity, immobilization and seizures. Then there are genetic disorders like glycolysis, fatty acid disease, mitochondrial diseases, inflammation like dermatomyositis, polymyositis, myalgia rheumatica, then bacterial infection, Clostridium, Klebsiella, Legionella, Streptococcus, Mycoplasma, Salmonella, Shigella. Viruses like Coxsackie, CMV, EBV, Enterococcus, hepatitis virus, herpes virus. Then ischemic injury like crush, compression, compartment, medications, your antipsychotics, barbiturates, benzodiazepines, chemotherapeutic agents, your clofibrate, colchicine, corticosteroids. Steroids cause muscle lysis. Remember it. Steroids very much can cause myopathy and muscle lysis. It's a very ignored fact. In fact, majority of people in India, especially in rural setting, are eating steroids and having their muscle lysed. Then there are narcotics, propofol, aspirin, statin, tricycline, antidepressant, zidovudine, etc. also cause muscle lysis. But steroid is very important cause of muscle lysis or myopathy. Approximately 800 to 1000 unit per liter of CK is required to call it significance, and for that much CKMB to rise, at least 100 gram of muscle should be lost. Myoglobinuria develops when skeletal muscle injury is more than 100 grams, and myoglobin is also a kind of hemoglobin. So myoglobin also contains heme. So dipstick does not differentiate between hemoglobin and myoglobin and RBC. It will just say positive. Doesn't matter if it's intact RBC, myoglobin or hemoglobin. You can also get a LDH level, and LDH will be elevated in rhabdomyolysis. So how will we treat traumatic rhabdomyolysis? If we have a victim of crush injury with prolonged extrication and transport time, मीन काफ़ी लंबे समय तक बेचारा क्रश होके वहीं फंसा था, so likely a significant amount of muscle has been lysed. So what will we do is we will give early and vigorous fluid. Assuming the kidneys are normal, we will give aggressive fluid. Approx 1 liter per hour of normal saline will be given. No lactate ringer, no Kbilite, nothing, because already the electrolytes, potassium, lactate, everything is so high already in the body. So we will not supplement any electrolytes. We will just give plain NS so that it gets flushed out. And after that, we will continue 500 ml per hour. So very fast fluid is required, we need a orange catheter for this. 1 liter per hour of fluid is required. Alternate the NS with D5 because rhabdomyolysis is associated with hyperkalemia and lactic acidosis. Avoid potassium and lactate containing solutions. Then once the patient is in emergency, aggressive IV resuscitation is done for the next 24 to 72 hours. 4 ml, 3 to 4 ml per kg per hour, and similar urine output is also desired. And there is no benefit from urinary alkalinization with soda bicarb, or no benefit of any forced diuresis. If bicarbonate is given, maintain an isotonic solution. Avoid metabolic alkalosis or hypokalemia. Mannitol may be harmful because it causes osmotic diuresis in hypovolemic patient. So soda bicarb and mannitol harm the kidneys. Remember that, है ना? Avoid करना है जितना हो सके. If you are seeing a patient with hypocalcemia in rhabdomyolysis, do not give calcium, है ना? It will resolve on its own. Calcium is given only if hyperkalemia is there. Hypocalcemia treat करने के लिए calcium नहीं देना है. Ultimately, you might need dialysis, and avoid NSAIDs or any nephrotoxic drugs till the first 3 days at least, so that all the things are flushed out from the body. The complications of rhabdomyolysis are acute kidney injury, acidosis, alkalosis, electrolyte disturbances, your DIC, compartment syndrome, peripheral neuropathy, है ना? Factors that contribute to rhabdomyolysis are already rhabdomyolysis induced AKI. When the rhabdomyolysis will lead to AKI are if your patient is hypovolemic, in acidosis or aciduria, tubular obstruction, and nephrotoxic effects of myoglobin. Renal tubular obstruction occurs secondary to precipitation of uric acid and myoglobin. So uric acid and myoglobin will jam the filters of kidney. There is a score called McMahon score to predict death or dialysis in a patient with rhabdomyolysis. So their components are calcium, create, CK, phosphate and bicarb. Calcium, create, CK, phosphate, bicarb. And then there are historical variables like etiology of rhabdomyolysis, age and sex of the patient. Next chapter is end-stage renal disease. So what was end-stage renal disease? Which was persistent AKI for more than 3 months and it requires dialysis. Why? Because our kidney does 3 jobs, which is excretion, synthesis and regulation. Excretion of more than 70 chemicals in the uremic plasma like cyanate, guanidine, polyamines, beta-2 microglobulin. So many things are excreted by the kidneys, and the excretion by dialysis depends upon the size, protein or lipid binding of the chemical. So dialysis does not remove all toxins. That's what I'm trying to say. Nobody can replace the kidney as such. Nobody can go on living on dialysis just like a normal human being without any complication to like live and die his natural death. No, it doesn't happen. Nothing can actually replace kidneys. Majority of excretory compounds are still there in your blood and they build up. They are not removed by dialysis. Such compounds which are bigger in size bind to protein and lipophilic. Then there is biosynthetic failure. We know that our kidney produces vitamin D3, active form of vitamin D3, which is your 125 dihydroxy vitamin D3, and it produces erythropoietin. Plus it regulates the phosphate and the GI calcium. It acts like a pH controller, a homeostasis pH controller of our body. It has a regulatory function. It regulates your atherosclerosis, your proteins, amyloidosis, your reactive oxygen damage, your acid-base balance, your electrolytes. In fact, kidney has 100% success rate, and kidney, we students can learn from kidney. Like, if you cannot get the concept in one go, revise again and again, so that you can get to 100%, even if it takes time, because we know that metabolic and renal compensation takes time, and the kidneys keep struggling. They don't give up. You give them tasks, they will try their best and they will get it done 100%. So kidneys are your filters and regulators as well as synthetic function which can never be replaced. What are the clinical features of uremia? So uremic encephalopathy, dialysis dementia, neuropathy. What is dialysis dementia? It is a manifestation of ESRD, and it becomes evident after at least 2 years of dialysis therapy, and it does not respond to increase in dialysis. Because maybe why it is happening? It is happening because of accumulation of lipophilic excreta which is not getting excreted by the dialysis. The dialysate water contains aluminium, and aluminium is a highly protein bound, so it gets accumulated in blood, keeps getting accumulated in blood and then the brain, and then it causes dialysis dementia, and there is no treatment. Dialysis simply cannot improve it. Then there are increased troponin I and T, and increase BNP also in dialysis CKD patient. There is raised troponin, hypertension, heart failure, uremic cardiomyopathy, pulmonary edema, cardiac tamponade, pericarditis. Dialysis related pericarditis due to buildup of middle molecules and hyperparathyroidism. So increase uremia also causes coagulopathy, anemia, and immune dysfunction. Other than that, there is hyperphosphatemia in the body. Hyperphosphatemia is going to stimulate your parathyroid hormone, which is going to break your bones and increase calcium in your blood, and this calcium phosphate is going to deposit in places that we don't want, like joints. So there is metastatic calcification of the joints causing pseudogout. There is calcification of the synovial membrane. It is calculated by a calcium phosphate product. We can multiply calcium in mg per dl into phosphate mg per dl. Both calcium and phosphate are multiplied in milligram per dl. If it is higher than 70 to 80, there is likely chances of more metastatic calcification. It can calcify small vessel, resulting in finger and skin necrosis, calcify the cardiac and pulmonary vessels. How we treat is sevelamer like phosphate binding gels and low calcium dialysate. Next, it causes beta 2 microglobulin amyloidosis. A beta 2 amyloidosis, A beta 2 kidney. What are the complications of dialysis? So inadequate flow, infection, bleeding, ulcerated fistula, vascular access aneurysm, and pseudoaneurysm. What is aneurysm and what is pseudoaneurysm? So aneurysm is dilatation of the artery. In the true aneurysm, there will be all three, like intima, media, externa, all three layers will be involved in dilation. While in pseudoaneurysm, it will tear the media and only the adventitia layer, externa layer will be having collected blood. That is pseudoaneurysm. True aneurysm में पूरा आर्टरी डायलेटेड होता है और pseudoaneurysm में आर्टरी का एक हिस्सा फट जाता है जहाँ से लीक करके जो है ब्लड उसमें भर जाता है एक्सटर्ना में, ट्यूनिका, इंटीमा, मीडिया, एक्सटर्ना में के नीचे भर जाता है ब्लड. How will we treat a vascular access hemorrhage? So first apply direct pressure for at least 5 to 10 minutes. Apply pressure with absorbable gelatin sponge with reconstituted thrombin. So we will use absorbable gelatin sponge soaked in reconstituted thrombin. So thrombin सोक्ड जेलेटिन स्पॉन्ज से उसको पैक करेंगे. प्रोटामीन देंगे 1 mg फॉर एवरी 100 यूनिट ऑफ हेपारिन. टूर्निके लगाएंगे प्रॉक्सिमल एंड डिस्टल. देन फिगर ऑफ 8 सूचर, ट्रेनिक्सा एंड स्टार्ट मैसिव ट्रांसफ्यूजन प्रोटोकॉल. Then a high output heart failure can also occur because of dialysis, because the heart wasn't built to actually support the flow through a dialysis circuit. So there is increased demand and reduced supply. What is Branham sign? It is a fall in heart rate after temporary access occlusion. Next, what are the complications during hemodialysis? It is dialysis disequilibrium. Dialysis disequilibrium is cerebral edema due to fast solute clearance. What happens during dialysis? Solute clearance occurs faster than fluid clearance. Again, dialysis can never be as accurate as your renal function. Kidneys used to do things slowly, but they did the things accurately. They did the things slow, but 100% correct. Dialysis is removing the solutes faster and the fluid is remaining, causing hypotonic fluid in the blood and cerebral edema. Treatment is 3% saline and mannitol. It is characterized by nausea, vomiting, basically cerebral edema, nausea, vomiting, hypertension, progress to seizure, coma, and death. Limit solute clearance when initiating hemodialysis. Slow कराना है and stop the dialysis. Administer 5 ml of 3% saline and mannitol. If there is air embolism, then clamp the hemodialysis axis and place the patient supine. There is no role of left sided up or Trendelenburg टांग ऊपर वाली position. You can Other therapies for vascular air embolism include percutaneous aspiration of air from the right ventricle, IV administration of steroid, full hyperinization and hyperbaric oxygen. So administer oxygen so it can get absorbed, basically dissolve and excrete from lungs. Peritoneal dialysis related peritonitis में if you do a cytic cell count, it will be more than 100 leukocytes, more than 100 WBCs with more than 50% neutrophils.